Good afternoon and welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month our topic is IVF, what do I need to know before starting? My name is Dr. Goulet and I'm here with Dr. Carmone and Dr. Fraterelli. Thank you for submitting your questions and joining us. We have a lot of great information to share with you. Let's get started.
All right, so I think we can start out by just going over what is in vitro fertilization, okay? And in vitro fertilization is kind of a broad category within the category of in vitro fertilization. There's all types of protocols, all different things that we can do, but basically what it is a process where we remove eggs from the body. We typically fertilize these eggs outside the body, and then we put embryos into the uterus. It usually goes along with ovarian stimulation. So we will typically give women medication to stimulate the ovaries so that we can remove more than just one mature egg. And then there are different options for how we fertilize embryos. But the gist of it is that some of the magic happens outside the body, although the pregnancy still occurs inside the body, of course.
Very nicely put. I think one of the common questions that I get from my patients is, do I need IVF? And after a workup, there's lots of different reasons that IVF may be indicated.
Yeah, and I guess we can talk about some of those indications, but a lot of times patients may not necessarily know what their indication, if they need IVF, until they obviously come in for an evaluation, and that's what the fertility evaluation is for. But there are some indications for IVF that patients really already know that they need, IVF. If someone knows that they have tubal factor, meaning that their tubes are blocked, then the sperm and egg can't meet, and so they have to IVF is their only option. If they have a severe sperm factor, which oftentimes they will not know, but if someone's had a vasectomy, for instance, and there's no sperm, or someone knows that they're not producing any sperm, then obviously, or not enough, or not much sperm, then there's procedures that we can do to help fertilize the egg. And one of the things with sperm factor that Dr. Carmone mentioned was ICSI, intracytoplasmic sperm injection, which in the early 1990s, ICSI became prevalent and really revolutionized what we can do for fertility. Until the early 90s, if a man had very little sperm, there was no baby coming. I mean, he was not going to have a child. Now we really need one sperm per egg, and one good sperm per egg, and we can fertilize an egg and create an embryo and help somebody get pregnant. So it was one of the, IVF obviously was one of the revolutionary things that happened, but then ICSI really changed things as well for men. And then I'll let Dr. Carmone talk about some of the other factors that patients may have that would need IVF.
So I think that some of the factors, as you mentioned, we know about, patients may already know, very low sperm count, tubal block. Some of the factors, though, don't necessarily need IVF as a first step, right? But we might kind of get to that point after trying treatments that don't seem to be successful. So for example, a patient who maybe has unexplained infertility, okay, and again, that's 20% of patients with infertility. So a patient who, for example, doesn't have a good or a known factor for why they're having trouble getting pregnant, maybe now they've tried a number of ovulation induction cycles with timed intercourse or IUI. Now at this point, they're ready for in vitro fertilization. For those patients, the reason that IVF tends to be more successful is I think there are two reasons. Okay, first off, IVF, there is a numbers game involved there. Okay, when we stimulate the ovaries, we're getting lots of eggs, and then we're looking through lots of sperm and hopefully finding the good ones and fertilizing lots of eggs with lots of good sperm. Well, just one sperm per egg. You guys know what I mean. And with the hope that we get some good embryos at the end of this. we're not trying to make an army of children. However, if we don't exactly know what the issue is, sometimes we need to get a lot of eggs so that we can get a good embryo at the end. And sometimes that part of it really is a numbers game. The other factor is that we're able to control a lot more aspects of reproduction when we're handling the gametes, the sperm and the eggs outside the body. So, for example, maybe there is an issue with fertilization that a patient with unexplained infertility is having that we don't know, because that's normally happening and it's inside your body. So I can't really see that or test for it. But now, once I have the egg outside the body, I can do ICSI. I can ensure, or I can try to ensure, that the egg and the sperm fertilize. And so I can control that part of it. I'm able to take a look at the embryo development. I can then go a step further and test embryos to see if they're chromosomally normal. So I can control a lot more aspects of reproduction outside the body, which may help to overcome certain factors that patients may not even realize are wrong with them. Other issues, for example, low ovarian reserve, advanced age. Okay. In those cases, even when ovarian reserve testing looks okay, if there is a subtle egg quality issue, again, then patients are going to benefit from us trying to obtain more than just one egg so that we can hopefully get a good one. If you've got a low kind of percentage of normal eggs in your ovaries, then we may need to get a lot of them to then find that special one. Similarly, we can treat that egg very delicately, ensure that it fertilizes, ensure that that we're kind of culturing the embryos in an ideal fashion, and then putting in that embryo at the right time, ensuring that the lining looks good with that cycle. So there are a lot of different things that we control here.
Yeah, with the advanced age, I think, you bring up a good point. Some of our individuals, when they're trying to get pregnant, they know their biological clock is ticking and they don't want to waste any time. They don't want to waste treatments or waste months that they know would be, maybe an ovulation induction with an insemination, but that the chances of getting pregnant that month are significantly lower than if they went straight to IVF. And because their ovarian reserve is diminishing quickly, it's very logical and reasonable at that point to go straight to IVF. And I think Dr. Carmone also brings up a wonderful point with this numbers game. I make the comparison a lot that in an IVF cycle, I might get out 12 eggs. That would be, I think a lot of people might get 12 eggs out during an IVF cycle, but that would be equal to ovulating once a month for over a year. So we are able to take an entire year's worth of ovulation and squeeze it into one fertility cycle.
Ooh, and I know what some of you guys are thinking though. Okay, you guys are thinking, oh my gosh, Dr. Goulet just told me that she's going to take a year's worth of my eggs. That's so messed up. And that's a very, very common misconception. In fact, I thought that too, like even when I first started, my residency. But so what happens every month when you release an egg is that typically you make just enough hormone to release one egg, but there's some number of eggs that become atretic or actually, die off that month. And that's something that we just can't stop. So even if you're on birth control pills, preventing ovulation, you still have that, same number of eggs that are basically dying every month. That's that biological clock. What in vitro fertilization is doing when we do a stimulated IVF cycles, we're actually rescuing those eggs that would have just died anyway in one particular month. And so those eggs would have never really seen the light of day. So we're not negatively impacting ovarian reserve. We're not removing eggs that would have become babies later, right? And we're not putting you into menopause sooner.
That's a great comment, Dr. Cohen, because I think that is something that a lot of patients will ask. The other thing about the numbers game is that when it takes a lot of eggs to make a baby. I mean, as humans, we're very bad at reproducing. There are, mice, almost every egg makes a little pup, makes a baby. But in humans, it generally takes, depending on somebody's age, 10 or more eggs to get one baby. I mean, when you're in your 20s, that number is going to be in the single digits, but when you're in your 40s, it may take more. The reality is it takes one egg to make a baby, but how many eggs does it take to get to that egg that is going to make a baby? And that's the issue. And that's why as women get older, it becomes harder to get pregnant because the eggs are less likely to make a baby. And that's why you typically need more eggs. And IVF gives you your best chance, for specifically when you're older, but at any time in your life. I think the other thing that we don't want to forget about is that there's another group of people who need IVF that may not necessarily have any of these diagnoses, and so single patients, single females, the LGBTQ community will need IVF in some way if they're not going to. Typically, if it's a female can do IUIs, but certainly IVF is another option for both for male and female patients.
I think there's some people were just asking some questions, so I thought I'd take a minute to answer those. How do you extract an egg from the ovary or uterus? So great question. The eggs are extracted from the ovary. So the way it works is that when we give you medication to stimulate the ovaries, typically your ovaries get much larger, and you can actually see the little egg houses, which are called follicles, and those are they look like little chocolate chips on the ultrasound. And then what we do when we do an egg retrieval is you undergo anesthesia with an anesthesiologist, and then I take a long needle, put it through the vagina into the ovaries. It doesn't sound pleasant, but it's actually not. It's not that bad. So, and you get anesthesia, so it's okay. But actually, the ovaries, when they're large, they kind of drop down to be very, very close to the vagina, sort of right above the vagina. So nobody ever likes to use the word puncture or pierce, but you just pierce right through there, and you actually get right into the ovary. It's a really minimally invasive procedure. People will feel some cramping potentially afterwards, but we make sure to take care of any discomfort in the recovery room, and most people actually feel completely fine. Some people will take Tylenol or ibuprofen later. Certainly there typically is not a need for more narcotics than that. People will go back to work the next day. And most people tell me that they feel completely back to normal by their next period. So
I think when people hear anesthesia, they think of what most procedures and most surgeries where you're getting intubated, right? And that's important to realize is that you're not getting intubated. You're getting a little bit of medication just to take a nap. The anesthesiologist gives you just titrates it so you get a little bit more, just so you're just taking a nap and breathing on your own. Although you are breathing 100% oxygen, we have oxygen on you, so you get really good oxygenation. But you're not intubated at all, and literally it takes 5-10 minutes to do. It's a fairly quick procedure with, as Dr. Carmon said, very little discomfort.
Yeah. I think there were some more questions. Do you have to weigh a certain amount before starting? I think that
it's a valid question.
That's a valid question. I think, that just depends on the facility that you're in, the capabilities that the facility have to take care of patients with either a higher body mass index or lower body mass index. I think it really depends on the particular center. And then if there are any other issues. So for example, if somebody is obese but has doesn't have any medical problems, then that would be different than somebody who is overweight but does have significant medical issues. And then I think there was another question.
And I think it is important to point out too, though, that with extremes of body weight, you do see lower success rates. So you don't necessarily have to have a normal BMI to undergo IVF, but certainly the healthier you are, the better your chances. And if you're at the extreme on one end or the other, too heavy or too thin, you do see lower success rates.
Right. And I think also what I explain to patients, because I do have a lot of patients ask me like, well, what should I do? Should I lose weight? Should I not? And I sort of also explain that you don't have to be perfect. If you were perfect, you wouldn't need IVF, like you wouldn't be here right now. So everybody in the waiting room has some type of issue that, that we're trying to overcome. And so I do tell patients, it's not like it's not like I'm not going to treat you if your fertility is not 100%, because obviously everybody has a problem. That's why you're here. And then lastly, somebody did ask if you can do IVF with an autoimmune disease. It really depends on the type of autoimmune disease that you have, how severe it is, whether it's under control, and whether whether your physician, whether that's a rheumatologist or not, feels that it's okay for you to proceed with pregnancy. I mean, certainly there are many patients of ours with autoimmune diseases that do proceed with healthy pregnancies.
And successful IVF.
Right.
Yeah, that can be the reason sometimes that individuals need IVF. All right. There are a handful of other reasons that individuals might need IVF. Not very frequent, but sometimes individuals know they have a genetic condition in the family. Either they've had an affected family member, or they've both tested positive for a carrier for a condition, and they want to do everything that they can to ensure that their child ends up as healthy as possible. And so with the cutting edge technology that we now have, it is possible to screen for single gene disorders and test our embryos, biopsy them and test them to see which ones are affected, which ones are carriers, and which ones are completely normal, so that we can choose the best embryos for transfer in that circumstance.
I thought that we could possibly, I can maybe just give a brief overview of, there's some very long questions. Okay, well, first, so let me continue here. So maybe somebody else can read the question while I talk here. But I thought it would be helpful to just go over an overview of practically what happens in an IVF cycle. And again, this does vary based on where you are, your facility, your physician, your protocol, and things like that. But so it's just really a very general overview. But essentially, there are a few different pieces to it. And initially, there's sort of usually a pre-treatment phase, then there's kind of a stimulation, and then there's the transfer phase, and those can vary. So typically with IVF, we may want to actually suppress the ovaries initially so that we can take over the cycle. And that's because typically your brain makes just enough FSH to stimulate and cause one egg to ovulate. But like I said, what we want to do is kind of overcome that mechanism. And sometimes the best way to do that is to suppress the ovaries so we can take over, and all the little follicles or little eggs start maturing at the same time. So typically we'll do that with something like birth control pills or pure estrogen pills, depending on what type of cycle you're on. And you may start that with your period or in the luteal phase at a different time of the cycle, but that'll continue for potentially 2 weeks or so. Again, very much depends. Then you will start injectable medication, which you take every day for approximately 10 days. Everyone's different with the length of time that they stimulate. That 10-day time period is where you're coming into the office a lot. All right, that's where you hear about IVF on TV and all these things. It's 10 days. It's not 3 months of shots, not 6 months of shots. People are surprised sometimes. I tell them they take shots for 10 days. People thought, I thought it was a year and a half that I'm supposed to be on these shots. No, you take these shots for about 10 days. You take the shots every day. We show you how to do it yourself. Okay, we really hold your hand through the whole thing. I think not just us, but most practices kind of will do a lot of teaching surrounding that. And then you come in every few days for us to check to see how you're responding. And then we can kind of turn down the medication, turn it up, depending on how things are going. At some point, we will decide that you're kind of ready for your trigger shot. And the trigger shot triggers your final egg maturation. So we give you that, and then we schedule your egg retrieval, which on average is around day 12. But again, this definitely varies. That's when you come in, undergo the anesthesia, take a long needle, put it through the vagina, collect the eggs. And now we can either do ICSI, where we inject each egg, or conventional insemination, where we just put sperm around the egg and see what happens. And then we let the embryos grow in a dish. Okay, now there's two options here. So we can either do a fresh transfer, where we put embryo into your uterus right away, or a frozen embryo transfer, where we transfer an embryo into your uterus about 6 or 8 weeks later. And that will make your IVF cycle about 3 months instead of 3 weeks. Most patients will actually benefit from frozen embryo transfer. There are various reasons as to why that would be the case. But it's actually more common at this point, at least in our practice and many others, to do a frozen embryo transfer than to do a fresh. So that's kind of IVF in a nutshell. Now you guys don't have to do any consultations with me because that's basically all I say in my consultation. So that's totally fine. And now we can just get started. You can just come in straight for your IVF cycle.
One of the more frequent questions I get is, should I do a fresh transfer? Should I do a frozen transfer? The idea of a fresh transfer is really attractive because it means you get pregnant sooner rather than later. But as you've mentioned, Dr. Carmone, the frozen transfer also has a lot of benefits to it. It gives us that time gap so that we can do any genetic testing on the embryo, like screening for abnormal chromosomal number, if that's something that our couples or our patients want us to do. But I also make the comparison that the IVF fertility shots that a woman is doing throughout her stimulation, those meds are really oriented to the ovaries. They're meant to make the ovaries do what we want to do. And oftentimes the uterus cooperates and plays along, and we can transfer an embryo and the embryo will take, but they're not necessarily medications specific for the uterus and oriented for the uterus. So by doing a frozen transfer cycle, we can then give a different round of medications that's really meant to optimally prime the uterine lining for optimal receptivity so that the embryo we transfer will stick.
I guess just to answer a couple of questions that we see. One question is, can I carry baby with scar tissue in my belly, and the other one is fibroids. If it's a C-section scar, we see that all the time. But the other thing that can happen is you can have just scarring within the abdomen that can cause tubal blockage. That can be secondary to endometriosis, can be secondary to a lot of things, and certainly that can that typically doesn't have an effect on IVF at all. We do need to look inside the uterus, at the cavity of the uterus, at the endometrium where the baby's going to grow, to make sure there's no scar tissue there and to make sure the cavity of the uterus is normal. Oftentimes we'll find little polyps or maybe a little fibroid that may need to be removed to optimize the pregnancy rate. And fibroids, it really depends on where they're located. A third of women have fibroids, and most of the time they're not a problem. If they get really large and they're affecting the cavity of the uterus, then that can be a problem. If they're inside the cavity of the uterus, that can be a problem. But those are procedures that we can do we can take the fibroids out. We can normalize the uterus as much as possible to improve success. So typically, most things are able to be fixed. And I would say that Dr. Goulet and Dr. Carmone, they're both young enough that they really never had to only do fresh transfers. They've always had the luxury of being able to do what we call delayed transfer now, where the IVF cycle really is a 3 to 4 month process. When I started IVF, it was a 1 month process. You started the medication for 10 days, you took the eggs out, you put the embryos in, typically around day 3 or so, and then you waited for the pregnancy rate. And we got really good at it. And then we realized that the frozen transfers, when we were thawing our embryos, patients didn't get pregnant with the fresh cycle. They would do a frozen cycle. We would thaw the embryos. Pregnancy rates were better with the frozen cycle than the fresh. And we didn't really understand that because we were putting the best embryos in, we thought, with the fresh. but the frozen cycles were a little bit better. And so after a lot more research, we realized that the stimulation, as Dr. Goulet said, the stimulation on the ovary to get the follicles to grow in the eggs can have a negative effect on the uterus, and the uterus doesn't really stay synchronized with that cohort of eggs really well, and so pregnancy rates can be a little bit lower. That doesn't mean that we don't do fresh transfers. We certainly do, but we individualize it for every patient to make sure that what we're doing is in your best interest. And so there are some patients that we'll do fresh transfers on, but the majority of patients who will counsel you during the process that the frozen transfer or the delayed transfer is going to be in your best interest for your best pregnancy rate.
Great. Should we talk a little bit about side effects, common side effects of IVF? Anyone want to?
Yeah, I counsel my patients that side effects of IVF are very similar to the symptoms that you might experience during pregnancy. Both are elevated hormonal states, and similarly, you might experience some bloating, constipation, irritability, maybe some hot flashes or nausea even due to the hormones. Also, during the IVF stimulation, you might experience a little bit of cramping, some growing pains of your ovaries. You're suddenly aware of some organs that typically stay relatively quiet. And these are all very normal side effects during the IVF stimulation. There is one severe side effect that we caution our patients about, and this is why we keep such a close eye on all of our patients during the stimulation, and that is a syndrome called Ovarian hyperstimulation syndrome. What happens is we can actually push your hormones too high too fast, and it can cause some electrolyte imbalances that could potentially even be life-threatening. It will put you in the hospital. We'll have to get an IV going and manage some severe nausea, manage your urinary output, and manage your electrolytes. And so it's something we very much avoid while we do your stimulation.
And I would say that is something that I, as older, used to have to do, not infrequently, because of the increased risk for patients, but it still happened rarely. It was, less than 5% of patients, less than 1 out of 20 patients would get, ovarian hyperstimulation, and less than 1% of patients would need to be hospitalized. Nowadays, because of the treatments that we have available, it just never happens. I mean, we haven't had anybody hospitalized for ovarian hyperstimulation in years. But with that said, everybody that undergoes IVF is getting ovarian hyperstimulation. That's the process, and we're hyperstimulating the ovaries to produce eggs. The question is, do you get the side effects? Do you feel sick from it? Reality is, very few patients do, unless you're in your 20s and you're making lots and lots of eggs. Most people are just going to have some abdominal cramping and bloating, and that's about it. But that is a very common question because it was such a problem 10, 20 years ago, and it really isn't anymore.
Yeah, so the modern protocols that we utilize make it pretty uncommon, even in patients who are very high responders. So it's very much dependent on the type of trigger shot that we use. So the type that, remember I talked about using that trigger shot, which triggers final egg maturation. So depending on the type of trigger shot you use in certain circumstances, you can drastically change the risk for OHSS. And so the modern protocols that we utilize, we don't see it very often. In addition, you don't see as severe ovarian hyperstimulation with frozen embryo transfers, which is also what we're doing very, very commonly at this point. So those kind of things together make IVF just a much safer procedure for patients overall. I don't know if anybody asked about it, but IVF may be covered by insurance in certain states. It is covered by most commercial insurance plans in Hawaii. So there is a state mandate here which requires IVF coverage, which requires insurers to cover IVF under certain circumstances. So it's not covered no matter what, you still have to meet certain criteria to be able to receive the coverage, but it is very, very helpful and makes in vitro fertilization affordable for patients and not just a luxury for the super wealthy like it is in some states, unfortunately. So I think that that's one of the best things about Hawaii is insurance coverage. That's what I love. That's what I love about Hawaii.
We live in paradise. That's, so it's one part of paradise. So, I will say that, Hawaii state coverage, we were like the second, maybe third state to have IVF coverage. Maryland was first. I think we were second. And it really, unfortunately, the mandate that was there in the 1980s hasn't really changed a lot. It's still the same. It's still, one of the things it says, if you've had it's like 5 criteria, and one of the criteria is if you've been exposed to DES. The last time anybody used DES was when I was born, and that was in 1967. So nobody is getting exposed to DES who's trying to have their own child using their own eggs. So there are some archaic forms of that mandate that we have been trying to work with the legislature to try to fix, but that really opens a can of worms. It really is a good thing that we have it because there does give the patients the ability to do IVF, like Dr. Carmon said. If you have tubal disease, if there's severe male factor, if you have endometriosis, again, associated with some other things, if you've been trying for a long time and haven't conceived, so that there are things that we always look for while we're evaluating the patients, or if you're wanting to do IVF, we look to see it, will your insurance cover it? And we discuss that with you at the first visit, at the second visit, whenever you're ready to have that discussion. I guess just to, I kind of teased everybody a little bit. So the mandate says, it's 5 years of unprotected intercourse is one of the, allows you the opportunity to do IVF. But typically you have to have something else, and you have to have something else in association with it. So, if you have tubal block, severe tubal block, the tubes are blocked, then you get IVF right away. You don't have to wait 5 years. If there's no sperm, or the sperm that's being produced is such little amount that only IVF will work, you can go straight to IVF. You don't have to wait 5 years. If you have other issues, endometriosis, and you've been trying and you've done IUIs, for instance, or ovulation induction, where we give you medication to help you ovulate and then put sperm into the uterus. Typically, like HMSA is like the most common carrier in Hawaii, and they a lot of their plans will require 3 IUIs prior to an IVF. Not all of their plans will, but there are certain things that you just have to look for, except for DES. We never evaluate patients for DES anymore, but the other things we always evaluate for to see if IVF might be available for you if that's what you need.
I think we should probably end on discussing embryo transfer, which is also a procedure that warrants some conversation. So the embryo transfer procedure is one which does not require anesthesia and is typically not as uncomfortable. So you come in, we place a speculum, we clean the cervix, and then we pick up the embryo and put it directly into the uterus. Typically, the catheter that we utilize to place the embryo into the uterus is very, very soft. And most patients don't really feel the transfer part. And it is overall kind of the fun procedure, okay, for most patients. We will often ask you to have a full bladder when you come in. So that part of it is not so comfortable because the speculum does put some pressure on the bladder. We use an ultrasound to help guide us to where we need to go. And that ultrasound does put pressure directly on the bladder as well. So I think that's really the worst part of the embryo transfer. Somebody was asking also, what is an IUI? I'll answer that here because it's a similar procedure. Okay, IUI is intrauterine insemination. That's not IVF, but that's where we take sperm concentrated and put it directly into the uterus. It's utilizing a similar type of catheter, though. It's the same idea where we take something and put it into the uterus. It's just when we do IUI, we're just putting sperm in the uterus, and all the ovulation, fertilization, and everything else happens inside the body. When we're doing embryo transfer, all that has already been done. We already have an embryo. That's what we're putting into the uterus.
Dr. Goulet, can you talk a little bit about number of embryos to transfer, patients that come in that want twins, and why that is an issue,
Yes.
and then maybe and tie all that in with success rates that we have?
Yes. So the American Society for Reproductive Medicine strongly encourage us to do something called ESET, which stands for elective single embryo transfer. And the reason why is because we know that singleton pregnancies are the pregnancies most likely to be born healthy, term, and without major complications. By increasing the number of babies that are growing, the rates of complications such as gestational hypertension, preeclampsia, hemorrhage needing transfusion, premature birth, all of those complications all increase dramatically when there's more than one baby growing in the belly. Now, a lot of twins do very well, absolutely. On average, most twins are born about a month early, maybe 4 to 5 weeks early, and most twins do spend a short-term stay in the NICU because they just need a little bit of support when they're first born. And most of those twins will be discharged home without any long-term problems. That being said, not all twins have a happy ending. Some twins are born extremely premature and can face lifelong difficulties because of their prematurity. And we don't have a way to predict necessarily who is going to do well carrying twins and who is not going to do well carrying twins. When all of our patients first establish care with us, their wish is, I just want a healthy baby. And so for me to accomplish that, the best way I have is to do a single embryo transfer. But by transferring 2 embryos at a time, I don't really increase pregnancy rates, but what I see a much higher rate of is the rate of twins, of course, as well as the rate of pregnancy complications. And so for that reason, I strongly encourage my patients to consider transferring just a single embryo at a time. If an embryo is PGT tested, and so we biopsy the outer part of the embryo, the part that becomes the placenta, and we send it off for genetic testing, and that testing tells us that embryo is normal, has the correct number of chromosomes, we have as high as a 60% plus success rate that will lead to a live birth and term pregnancy. Really the success rates go up when we do a single embryo transfer.
Yeah, and one of the common questions we get initially when we start to do an IVF is, what is my success rate? We'll oftentimes get that at the first visit, right? And we don't know. We don't know what your success rate is going to be until we get an embryo, until we see what the eggs are like and what the embryos are like. And once we get to the transfer part, then we can give you a realistic expectation of what your success rate is going to be with a particular embryo. But in the beginning, when I'm talking to a patient, it's based on your age and your hormone levels and what your ovaries look like, and it's basically our best guess as to what pregnancy rates will be. But a 45-year-old patient, who walks in my office, she has a 1% chance, 1 to 2% chance of having a baby. However, at the time of the transfer, if she actually went through an IVF cycle and did PGT on her embryo, and she has a PGT normal embryo, now she has over a 50% chance of having a baby. So that's a big difference. And so that's, the unknown. So at the beginning, we're giving you the success rate of what kind of the average with your age and everything else that we would see. But it really is that end result that then we can give you the best estimate.
And ultimately, it's so hard because it's just probabilities. So, I can tell you've got a 70% chance for getting pregnant, but if you don't get pregnant, you're not pregnant. So it's numbers are great when we're doing research and when we're studying things and trying to figure out how to give patients their best shot. But ultimately, when you're a patient, you kind of do have to take some of those numbers with a grain of salt, because you just have to understand that this is a process that's supposed to hopefully improve your chances of getting pregnant, compared to not doing IVF. And so that's really your best shot. And I think that if you kind of delve too much into the probabilities, it can get really, really difficult to tease out what is your exact number and chance for getting pregnant.
I'd like to say probably at the end, it's always, when we have patients and they come back and bring their babies back for us to see the babies, it's always very humbling and I think very amazing. I am truly amazed, not at what we do, but what happens. I see the egg, I see the sperm, and now I see this baby, and how did all that happen? And it really is, and all the things that we've done to that egg and to that sperm and to the embryo to get it to be a baby. It's truly amazing that the technology is there that can produce these wonderful families for patients. And again, I think I've said this before, if you enjoy what you're doing, it's really just a hobby every day that I'm coming to work. I love being here. I love doing what I'm doing because of it. And obviously we do have some patients that don't have success, and that's always very sad, and that hits us very hard because you do take that personally. But the successes are what keep us coming back and keep us enjoying our job and enjoying our work.
All right, perfect. Well, I think this is a good place for us to stop, since we kind of went through everything detail by detail here, and hopefully you guys have a better understanding of what you're in for. I know that there's a patient who was asking me what the next steps are. For her in particular, I'll have my staff contact, and hopefully we'll get her all set up for everything that she needs. So.
Well, one of our former staff members, Shara, chimed in earlier too, saying hello, Team FIH. Shara was here for a long time. We really miss her. Hi, Shara.
Hi, guys. All right. Well, thanks for joining us, and we look forward to seeing you guys with our next Facebook Live session. Okay. Bye.
Bye. Aloha.